Welcome to this week's ACCP Emergency Medicine PRN Journal Club presentation. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/ACCP-EMEDPRN. And for PRN members, slides can be found under the Library Entries section of the ACCP Communities website.
I'll be presenting today on a journal presenting the safety and tolerability of intravenous push, Lacosamide, and Levetiracetam. Before we get started, neither I nor my preceptors on this presentation have any potential conflicts of interest. However, some medications mentioned throughout this presentation may reflect some off-label indications and administration techniques. To get started, the diagnosis of status epilepticus is defined in the neurocritical care guidelines as 5 minutes or more of continuous clinical or electrographic seizure activity, or any recurrent seizure activity without recovery between seizures, and then it's further categorized into convulsive or non-convulsive status epilepticus. The treatment of status epilepticus hinges upon benzodiazepines as the first-line treatment for emergent initial therapy, and then moves on to urgent control therapy with the medications listed here. And then the treatment of refractory status epilepticus recommends these medications for the treatment of that based on the neurocritical care guidelines. Something I wanted to highlight is the control of refractory status epilepticus should be established within 16 minutes of onset. And for this presentation, we're going to be focusing on these two medications here, Levetiracetam and Lacosamide. We're going to start off with the utilization of Levetiracetam for urgent control therapy. The mechanism of action is listed here. In the dosing or the bolus dosing of Levetiracetam for patients experiencing status epilepticus is 40 to 60 milligrams per kilogram with a max dose of 4.5 grams per dose. And here in Texas, our patients are pretty big, so we often utilize the max dose a lot. And based on the package insert of the medication, it is recommended that it is diluted in 100 milliliters of either normal saline, lactated ringers, or D5. And it's recommended that it's administered over 15 minutes via infusion. And listed here are some adverse reactions that you might see. And then I think most of the studies also studied any hypotension and bradycardia as well. The first comparative study, I'll say, that really looked at push dose versus IV piggyback infusion of Levetiracetam was by Lacosamide et al. Its population included anyone who received IV Levetiracetam greater than 1,000 milligrams, and they were adult patients. And then they excluded patients with a baseline systolic blood pressure of less than 90 and a baseline heart rate of less than 50 beats per minute. Listed here is an intervention group and the amount of doses in each group. The IV piggyback was infused over 15 minutes per package insert, and then the rapid infusion, which was the IV push, was pushed over 5 minutes. Of note, in terms of the patient populations, 52.8% of the patients received the medications peripherally, and then 25.4% of patients received it through central venous access when it came to the IV push. And then regards to the IV piggyback infusions, most of the patients received it through peripheral access. To summarize the outcomes of this comparative study, there wasn't a significant difference between IV piggyback infusion versus IV push Levetiracetam when it came to administering these doses to the patients. And then sedation within 6 hours was also non-significant, although it was a little higher in the patients who received IV piggyback. And then also, in regards to efficacy, when they talked about time to administration and time to dose completion, there was a significant reduction in time to administration and time to dose completion when patients were administered Levetiracetam via IV push. Obviously, with IV push, you cut out a lot of the compounding and logistical needs in between. So in conclusion for this study, IV push Levetiracetam administrations of doses up to 4 grams has similar incidences of adverse reactions compared to the IV piggyback administration, but however, there was a significant reduction in administration time. The next medication talked about in the current study presenting in this journal club was Lacosamide, utilized to treat refractory status epilepticus. The mechanism of action is listed here. In the dosing of Lacosamide, the IV load is typically 200 milligrams to 400 milligrams. And then the IV maintenance dose is 100 to 200 milligrams twice daily. Per the package insert, the preparation and administration of lacosamide is recommended to be diluted in 100 milliliters of normal saline, lactated ringers, or D5, and it's recommended to infuse it over 30 to 60 minutes. And then another logistical point I want to point out with the administration and preparation of lacosamide is the diluted IV infusion is stable at 4 hours at room temperature. And then listed here are some of the adverse reactions to look out to. The study right here is another study that compared IV piggyback lacosamide to IV push lacosamide. It was by Davison et al. And that was in 2018. It included patients who received one dose of IV lacosamide at any dose and received IV piggyback. It excluded anyone who had like crossover in the study. IV lacosamide and the IV piggyback was administered per the package insert over 30 minutes, and the IV push was administered and pushed at a maximum rate of 80 milligrams per minute. So, for example, if a patient was receiving a 400 milligram IV load, it'll be over 5 minutes. And the outcomes evaluated here with bradycardia and hypotension which was non-significant between the IV piggyback and the IV push group. However, it was only numerically elevated in the IV push group. There were no infusion site reactions, and the median time to administration was actually significantly lower in the lacosamide group. So in conclusion for this study, IV push administration of lacosamide showed a vast improvement in administration efficiency without a significant increase in adverse effects. And also, as y'all know, lacosamide is a controlled substance, so there's also added logistical difficulties when it comes to that as well for the preparation and administration. Moving on to our current study. Our current study for this journal club was a retrospective observational study collecting patient data from September 2019 to May 2020. And it was conducted at Tampa General Hospital. It evaluated patients who received lacosamide IV push over 5 minutes with a maximum dose of 400 milligrams and levetiracetam IV pushes over 5 minutes with a maximum dose of 1,500 milligrams. It included adult patients that had received either one dose of IV push lacosamide or levetiracetam. So there was opportunity to study patients who have received both of note. And then also for exclusion criteria, they sort of mimicked the previous studies and excluded patients with reduced systolic blood pressures less than 90 millimeters of mercury, and also if they had a baseline heart rate of less than 50 beats per minute. 96 patients were screened for evaluation, and then 36 patients were included in the lacosamide arm, and then 50 patients were included in the levetiracetam arm. Within 2 hours of administrations, the study conductors were looking for any incidence of hypotension, defined as a systolic blood pressure of less than or equal to 90 millimeters of mercury, and any incidence of bradycardia, defined as a heart rate of less than 50 beats per minute. Secondary outcomes they were evaluating include any incidence of infusion site reactions, or any PR intervals that are prolonged. So any PR intervals greater than 200 milliseconds. Categorical data was described using descriptive statistics, and continuous data was described using mean and standard deviations or medians for non-parametric data. When it came to study the baseline characteristics, their mean age was about 65, and then a predominantly male population, pretty evenly split actually between males and females. And the median dose for lacosamide group was around 200 milligrams, and the median dose for levetiracetam group was 500 milligrams. 69% of the patients in the lacosamide group utilized it for seizure treatment, and then levetiracetam, 44% of the medication was utilized for actual seizure treatment rather than prophylaxis. This graphic here, just to orient y'all, the lacosamide administrations, a majority of the lacosamide patients received 200 milligrams of lacosamide IV push, and some received 100 milligrams. Looking that like 200 milligrams might have been the load, and then the 100 milligrams may have been maintenance doses. And then when it came to levetiracetam, a lot of the patients received 1,000 milligrams and 1,500 milligrams and 500 milligrams. Looking at the primary outcomes listed here, hypotension and bradycardia. So with hypertension, it occurred in 11% of the lacosamide group, and then 5% of bradycardia occurred in the lacosamide group as well. And with regards to levetiracetam, 4% had incidence of hypotension and 8% had an incidence of bradycardia. And there were no incidents of infusion-related events or PR interval prolongation. Unfortunately, this study wasn't really a comparative study. It was very much a descriptive study, but I'll put it in more context compared to the other studies that preceded it. So we're going to start off with the IV push lacosamide trials here. One by Torian et al. Davidson we talked about earlier, and then McLaughlin and Ranungen is our current study that we're presenting in this journal club. So McLaughlin et al. Was the only study that really evaluated peripheral and central line administration of lacosamide, where a majority of the patients received it peripherally, and then about 1/3 of the patients received the IV lacosamide centrally. And then a lot of these studies occurred in the ICU. A lot of this with regards to IV push, and then a lot of the studies included doses about 200 milligrams. Very little of these studies in the data describe the utilization of 400 milligrams, except for really Torian in 2023. And then Torian set out to actually describe the higher doses of IV lacosamide here. And with regards to the adverse events between these 4 studies, including our current study we're currently evaluating, our current study reflected the adverse events of previous studies, with hypotension being probably the most common adverse event with IV push lacosamide, occurring about 10% of the time. And then bradycardia in our study occurred 5.6% of the times. And then it was sort of varied between Davidson, Torian, and McLaughlin. And then with regards to PR prolongation, our study didn't see any, although we had a pretty small patient population compared to Torian et al. They saw a little higher percent of PR prolongation there, but they only did have 21 patients collect QT data for that adverse effects. Moving on to IV push dose levetiracetam trials, we have 3 trials. Lacosamide et al., Ranungen et al. Is our current trial we're describing, and then Adams et al. In 2021. Again, here, Lacosamide et al. Was the comparative trial we described earlier in the background. It described the peripheral access and central administration, and then also the doses here sort of maxed out and capped at 2 grams. So these studies didn't really evaluate the maximum 4.5 gram loading dose utilized as a push, and then any adverse events associated with it. And then a lot of these studies occurred all completely in the ICU. When it came to adverse events reporting in between these 3 studies, up to 2 grams of IV levetiracetam was pretty well tolerated when it came to bradycardia, hypotension, and then any other adverse events as well. And then Adams et al. Was the one only evaluated any dose decreases when it came to dose adjustments required. And then they also evaluated any need for utilization of benzodiazepines as well, which was not significant. So going back to our current study we're evaluating, the strength was that this study was the only study that evaluated concomitant IV push lacosamide and levetiracetam in these patients. And then they evaluated the utilization of both levetiracetam and lacosamide in prophylaxis and acute treatment for status epilepticus. And the data collection and outcomes modeled the other studies surrounding the safety of IV push levetiracetam and IV lacosamide. The limitations of this study was that it was a retrospective observational study. There wasn't a lot of comparing between IV piggyback and IV push. With regards to adverse drug reactions, they didn't utilize the adverse drug reaction probability scale to sort of put those adverse drug reactions in context. This study lacked IV access documentation, so this would be difficult to sort of utilize this study in terms of translating to practice if we can push it peripherally safely. And then they didn't really evaluate any efficacy outcomes as well when it came to IV levetiracetam or lacosamide. And then all the patients in this study was located in the ICU. The authors concluded that IV push administration of both levetiracetam and lacosamide were probably safe and not associated with any significant adverse events. And then IV push seems to be an safe alternative method for administration for both these medications. Personally, I thought the safety outcomes largely reflected the safety outcomes of the previous studies. Lacosamide doses less than 200 milligrams and Levetiracetam doses less than 1.5 grams can be safely pushed. However, there are more studies needed to evaluate the safety of pushing doses greater than these two doses. When evaluating the surrounding studies, IV push lacosamide and levetiracetam did significantly increase medication administration efficiency, so it's definitely worth looking more into the higher loading doses of both of these medications. And with that, I want to thank my preceptors, Dr. Megna Valab and Rebecca Kissinger, for helping me with this presentation. And I open the floor to any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.